Hans said in the introduction, what I'm going to talk today is about the EFSUMB guidelines. Quite clearly, the guidelines is not really for the experts, as there are a lot of experts here in the room already. I know, I've seen their faces. But it's really, the guidelines is really for those who want to start doing contrast lens ultrasound. And as Hans said, we had the original guidelines published in 2004. And this is really a small update, I would say, especially when it comes to the liver indications. And what I'm going to talk to you again today is not about the whole guidelines, but specifically with regards to using CEUS in the liver. Now, we all know the benefit of using contrast compared to not using contrast. And you can see from this quite old slides, actually, that's from Peter Burns, which really show in the late phase how you can increase the signal intensity of the liver quite significantly with the use of contrast. And as we know, liver tumors do not take up the contrast, and therefore, in terms of liver tumor contrast ratio, you can see there is a 7-fold in the benefit of using contrast. And that clearly would lead us to be able to identify tumors which we would normally miss without using contrast. So as you can see from the conventional video loop, as you can see from the right lobe of the liver, we kind of spot something abnormal in that region, and quite clearly you can see much better following the contrast administration in the same area. So this is a huge difference, right? And if you look at from this slide, this is the 3D acquisition from the same liver, and the right lobe is, as you can see quite clearly, is studded with multiple lesions. So there's a clear benefit of using contrast in being able to do accurate detection of small liver tumors. So on the basis of a lot of the evidence done from various centers, I mean, I can name papers back from 2000 up to now, really showing the evidence. So this list is really based on evidence. That contrast does help detection of focal liver tumors. Now, the one clear indication, whereby we would certainly recommend using contrast, is that if you wanted to rule metastasis or abscess, unless these is so clear on your baseline scan, that you should really be using contrast. So that's really the first one. The second indication is, as stated there, in selected cases for treatment planning, to assess the number and location of metastasis as a complement to CT and MR, even these contrast lens MR and CT scan. Now, and I guess there are several scenarios to that, because remember, if, for example, you're trying to do an RF ablation on the tumors, and these scans have been done weeks before, and if you want to do a more updated stage of the liver, you really want to use contrast to really assess the true extent of the disease in the liver parenchyma. The third area, which may be a bit more dubious depending, I think, where you work and what all your resource facilities are, is in the surveillance of oncology patients, where CEUS, that's why we specified before, that CEUS had previously been useful. Meaning that if you've been able to find a lesion before and this patient goes on to chemotherapy, and you really want just to look at the effect of the chemotherapy on that patient, you could use contrast. The fourth indication is really when you suspect there is cholangiocarcinoma, for example, anybody with biliary tree obstruction, and you think there might be a mass causing the biliary obstruction, and when other imaging modalities, such as CT or MR, are inconclusive or scheduled. And there has been evidence, certainly from the Toronto group from Stephanie Wilson, using an old contrast agent, Levervis. They've actually shown in relatively small number of patients, 35 patients, whereby they actually showed that the use of contrast actually delineates cholangiocarcinoma much better than CT scan. So there is no doubt about the value of CEUS for assessing the extent of cholangiocarcinoma. And the fifth one, I'm pretty sure will be covered later on by Lars Dorelius in some of the later lectures, is really with regards to suspected liver trauma. Now, in what sort of conditions should we really apply contrast in trauma? I mean, the first one, as mentioned here, is for monitoring of known traumatic lesions, which actually means that we know there has been a laceration or like a hematoma on the basis of CT scan, and we want to know whether this hematoma is regressing or progressive so that we can see whether we can discharge the patient or not. So I think it's fairly legitimate to actually use contrast in this kind of circumstance. The next one, which is interesting in the sense that, in children, although none of the agent is actually licensed for the use in pediatric care, one will have to request local ethics acceptance in using contrast in children in the first place. But I think it would be wise, given that you don't want any radiation in children, using CEUS would be appropriate with the help of your ethics committee. And lastly, the indication is when the patient requires resuscitation before CT scan. Now, as you know yourself, it does take some time when the patient is acutely admitted in casualty that you don't get a CT scan, and yet you know this patient is actually bleeding profusely or for whatever reason. There is a case for you to actually use contrast while you're doing your baseline ultrasound in the first place to see if there's any bleed inside the peritoneal cavity, to actually at the same time at contrast to see whether there's actually laceration in any of the solid organs. So that is for the indications on detection. I just want to show you a video of the laceration. You can see this is the arterial phase here. We see this stab going through into the liver. And while you wait for the late phase, you can see quite clearly these areas of laceration or hematoma. And you could also track and see whether there's actually active bleeding by doing second re-injection if you need to. In the next series of slides, I'm going to talk about the indications for characterization. And this really falls the big part of the indications in the liver. We've already heard about the limitation of conventional technique in itself in terms of characterization. This is fairly straightforward. I just really want to show some examples. I'm pretty sure a series of lectures later on will show you the different characteristics and defined features of various tumor types. But just really here to give you an example, the baseline scan of this metastasis, which is heterogeneous. Typically, these metastases enhance with rim enhancement with central areas of necrosis, and in the late phase, you get washout, and the lesion is clearly defined here. When it gets to hepatoma, this patient has got background liver cirrhosis. Even in the background liver, it's a fairly large tumor. You get the pseudous capsule being seen. Arterial phase, the lesion lights up like a bulb. You got intratumoral vessels, as you can see, like basket pattern, and you got this pseudo-rim, pseudo-tumor capsule that doesn't enhance until in the portal phase. And characteristically, in the late phase, you get complete washout, or sometimes you get a bit of holdup in the hepatoma. Hemangioma, we've already been told before, we're looking for the centrifugal or centripetal filling in of the tumor as time goes on. You can see the lesion as you keep on looking in time, gets smaller and smaller, and eventually you may have complete filling of the lesion. And the last of the group of lesions which we commonly see, baseline FNH, isoechoic to the adjacent liver. Color Doppler may show you the spoke-wheel distribution of the arteries and sometimes the central artery, but characteristically when you look at the arterial phase, you should see the lesion lighting up very briskly and going from in, out, and more importantly in the late phase, as most benign lesions, there are isoechoic to the adjacent liver. So with these kind of features which I just described, I showed 2 malignant ones and 2 benign ones. And if you got hold up of contrast in the late phase, it's benign. If you get washout, it's more likely to be malignant. So these are the indications here for characterization in the guidelines. Basically, we would advise to use CEUS in patients with uncertain liver lesions, in particular, these 4 conditions. Now, we routinely pick up these lesions and not sure what they are, and quite clearly, as an incident finding, it would be wise to use contrast to ensure that it is benign. Now, lesions suspected in chronic hepatitis and liver cirrhosis, as we said already earlier on, this can be a very gray area, and I'll show you the flow diagram later on how we make the characterization of different tumor types in the background cirrhotic liver. The third incidence is when the suspected lesions with history of malignancy. And as we know, surgery lesions do exist in these patients with a known history, and the risk of actually a single lesion with a known background liver and external primary is about 10%. And you don't really want to take that 10% risk. There's been numerous studies on CT scan as well as ultrasound that actually showed, for example, that the risk of actually having a malignancy in the liver on its own, if you don't have a primary outside found, is actually almost zero. So, you would use CEUS in this kind of circumstance, especially when you have a history of malignancy. And lastly, And this is a growing group of patients that we see, especially if you have a big liver unit whereby they do liver resection, liver transplant, is really there are patients that come with liver lesions that are inconclusive, not just to MR or CT scan, but also sometimes the pathologists do not know the answer. So these are the clear indications of where we would use CEUS. Now, I said to you, what I think is, well, this particular table is not particularly new in the guideline, but what we've done is really updated a few things. For instance, we've looked at the features of the HCC when the background liver has cirrhosis, and in cases where there is no cirrhosis in the liver, and what would the HCC findings would be in the arterial phase, portal phase, and in the late phase. I don't really want to go too much into detail with these tables. I'm sure it will be covered in a series of lectures after this talk. Metastasis is fairly straightforward. In fact, irrespective of what happens in the arterial phase, in fact, almost 100% of these lesions will be hypo or non-enhancing. There are other lesions got cystic metastasis, and clearly the behavior of the solid component would be the same as in metastasis. And cholangiocarcinoma behave very similar to the metastasis. This table here illustrates the features in the arterial phase, portal phase, and late phase for the benign group of lesions. And this really, by and large, hasn't really changed that much compared to the first edition of the guidelines. But what is new in the updated 2008 guidelines is this algorithm. And this is, again, based on results of previous studies. So it is evidence-based. Now, it is quite clear. This is really to facilitate making the diagnosis or the characterization of these focal liver tumors. So in a normal liver background, you find a lesion. The algorithm is such that you start up with what you find in the late phase. All right? If there is sustained enhancement in the late phase, if it is yes, the chances are going to be benign. Okay? And by using the arterial features of what you find, then you can come to the conclusion as to whether it is FNH, hemangioma, adenoma, or focal fatty change. And if there is no sustained enhancement, the chances are that it is malignant. And again, by looking at the arterial phase, you can differentiate whether this is metastasis, HCC, or cholangiocarcinoma. And what we've added onto the guidelines is how do we go about characterizing lesions when you have background liver cirrhosis. Now, as opposed to the normal liver, now what you start in the algorithm is ask the question, in the arterial phase, is it hyper-enhancing or not? If it is yes, and then you look at the late phase, it says it washes out or is less than hyper-enhancing, it's clearly an HCC. The difficulty now comes when it is not hyper-enhancing in the arterial phase, especially for these two groups here. As you can see, if now in the late phase is iso-enhancing, that is the same density as the adjacent liver parenchyma, then your differential diagnosis slightly increases. And the difference when you look at these two here is based down to experience. This is quite good as a startup. It's not meant to be complete. It's not meant to be the goal, the Bible or whatever. But it is a guide. All right? Mistakes are going to be made. But I think as you develop your own experience, as you work with your pathologists or your clinicians, you'll improve the way you make your diagnosis. But I think the last one's very straightforward. That in fact, if you got the washout to pronounce hyperenhancement, you look at malignancy. And this one, the key thing is not so much about the washout, but also the peripheral nodular centripetal enhancement. We now come to the third indication in the liver, which is really monitoring ablative therapy. Now, in any ablation, I said to you, it is always worth staging the disease at the time of the procedure itself, as opposed to refer directly to the CT scan or the referral scans, which could have been done anything from 3 to 6 weeks before. So even in a period of 3 weeks, I can tell you, things do change. So restaging at the time of procedure is critical. This is a hepatoma, as you can see here, enhancing in the subcapsular area. And the next step, once you've identified the lesion, you want to be able to target your lesion accurately. And that's very straightforward. You put in the needle because you still see the lesion, so you don't need contrast in that instance. I'm just going to skip a view of these. So that's what it looks like before the ablation. And what you want to see is whether you achieve complete ablation. and you want to make sure that that area is completely devascularized. Okay. Now it depends what the time you do it. You may find peripheral rim enhancement. This is the benign enhancement that you see from hyperemia. So these are the indications now for monitoring RF ablation. The first one I said to you is re-staging and assessment of the target vascularity. Now remember, this is not to say that you don't use CTMR, by the way. Okay. So that's why this statement is put behind. Now, to guide needle position, because quite clearly there are lesions that you can only see with contrast. So how do you go about to target the lesions that you don't see except with contrast? And I'll show you by the use of the dual screen in a later slide how you could do that. The third one, as I said to you, is the evaluation of the immediate treatment effect of the ablation. That is really after 5 to 10 minutes when the native gangs from the ablation have subsided or resolved, and allows you to apply contrast. And lastly, is really to follow up to see whether there is any tumor recurrence. I'm looking at on a 3-monthly basis this time as opposed to the peri-procedural period. And specifically when CT and MR are contraindicated. Say, for example, the patient has got iodine allergies or have got renal impairment. Now, as you can see here, there's another sub-statement. Although CT-MR considered as gold standard, but we do recognize that CEUS, especially in the case of hepatoma monitoring, has a great value in terms of follow-up protocols. So I just want to show this video here to show you how we can actually target by using this dual screen. Most ultrasound companies do have this dual screen whereby you have the grayscale fundamental mode and you have the contrast nonlinear mode here. Now, the reason why I show that is important because in the contrast mode, even the needle will get subtracted unless it's moved. As you can see now, when it's moving, you see it, all right? But you don't see the lesion in the grayscale mode, but you see the lesion in the contrast mode. So the side-by-side is actually very useful for targeting lesions, whether it's biopsy or ablation. What are the features to us in terms of that we need to look for to ensure that response has been achieved? Complete coagulation is when the volume is much larger, and we have complete loss of the enhancement. And that's typically for the hypervascular tumors. But so the hypervascular tumors, what we're really looking at is that the volume is much larger. The ablation zone is much larger compared to the original size of the tumor. What are features that make us suspect there is residual disease is really the reverse of the two. But also, I think one of the key points here is when the margin is still defined. As you know, if there is residual disease or recurrent disease, they show features of neovascularization just the same way. And what we're looking is that if there's residual tumor or peripheral tumor, that they will enhance in the atrial phase, and they'll definitely wash out in the portal and lip phase. And this is really what we want to see: large ablation zone, complete devascularization of the ablation zone. And this is the correlation with the MR scan. It's just ready to show you the effect. So finally, to really summarize the guidelines for the liver, there are clear indications for detection and characterization of focal liver tumors. And I think it is also essential to use contrast when we're looking at doing ablative therapy. Thank you.